Thank you all so much for attending today. Um, I'm very pleased to announce our presenters for today. So those of you that don't know about the remedē system, it is a transvenous phrenic nerve stimulator. We'll talk about it a little bit later in the program. But first, I'd like to introduce our speakers. Dr. Rami Khayat is a board-certified pulmonologist and sleep medicine specialist who's a nationally recognized expert in sleep disordered breathing. He's the Director of Health Sleep Services, the Division Chief of Pulmonary, Allergy, Critical Care Medicine, and professor in the Department of Medicine at Penn State. He earned his degree from Tishreen University in Syria and completed his internal medicine residency at the Medical College of Wisconsin in Milwaukee, followed by pulmonary critical care and sleep medicine fellowships at the University of Wisconsin School of Medicine and Public Health in Madison. And he was recently asked to be part of the team for the 2025 AASM CSA guidelines. And also we have today Professor Randerath from Germany. He's a prominent German physician and an expert in pulmonary allergology and sleep medicine. He's widely recognized for his leading role in developing clinical guidelines for the European Respiratory Society. And he currently serves as the chief physician and medical director of the Clinic for Pulmonology, Allergology Center for Sleep and Respiratory Medicine at the Bethanian Hospital in Solingen, Germany, and also directs the Scientific Institute for Pulmonology at the University of Witten-Herdecke. His work includes developing clinical guidelines for the European Respiratory Society, leading to the creation of the modified Baveno classification system for obstructive sleep apnea and membership in international scientific societies like ATS. Professor Randerath has also published extensively on sleep apnea and other respiratory topics. So thank you both very much for being here today. We're quite honored to have you join us for this discussion-based program. We're going to start out with just a few slides to just ground all of you that are attending in the new AASM guidelines as well as the recent ERS update. So with that, I'm going to ask Dr. Khayat to kick it off with an overview of the recent CSA guidelines.
Thank you very much, Robin. Truly honored to be here with Dr. Randerath. And as you know, he was instrumental for these guidelines as well. Without further ado, I guess I'm going to just tell the audience a little bit about what the background was for doing this, because sometimes people, wonder why we needed guidelines at this time versus that time. And I think everyone, I think on this call obviously is here because they're very interested and knew it's a timely question. The whole field was waiting since 2012 for some update on the guidelines we had then. And the field of central sleep apnea had seen a lot of changes since the first guidelines that the AASM put out. And two of the main developments were the FDA approval of the transvenous phrenic nerve stimulation, which you were instrumental in, amongst others. And, it was a great treatment that the clinicians needed to know how it fits into what they're doing. And the other change was the development, the publication of the trials on ASV, including specifically the Advent HF. So these two things, along with a lot of the questions that were left over from the previous trial on ASV, the SURF HF, left our field really in disarray and in need of some form of guideline and sorting through the data to help our clinicians and patients. So there was a lot of pressure on the AASM to do something from that standpoint. So the AASM had, in the meantime, developed a process too of doing these guidelines in a very systematic, impartial, dispassionate way, with very strict guidelines for conflict of interest management and using a system called grade methodology. From the time the task force was commissioned till the publication was almost 3 years of work following these systematic guidelines. And to just orient the audience, because this actually applies to this particular set of guidelines about central sleep apnea, but applies also to all the guidelines the Academy puts out. And I think we all, as practitioners, should be familiar with this approach. So this GRADE approach involves collecting the evidence, collecting all the literature, and then putting it in a process with supervision of a methodologist, to minimize any potential bias, and looking at grading the quality of evidence with preset criteria. So, for example, randomized controlled trial of adequate size versus observational study. You rank these based on their level of evidence. And once all the studies or the literature is accumulated and accounted for, the process goes by PICO, and PICO stands for population, interventional, comparator, and outcome. So we set up these questions based on what we know about the population that's affected by the disease. So we would say patients with central sleep apnea due to heart failure, patients with central sleep apnea due to something else. And then we look at the evidence for treatment for each of these populations, and we grade them or rank them by benefit versus harm, their resource use, and what we know patients would value and prefer, and that's based on available literature as well, and sometimes based on clinical experience. But what's so important in these types of guidelines is that all the outcomes are set before we start the process. So the group, based on what we know about the literature and what the literature is telling us, put what's critical outcome for central sleep apnea specifically, as you see here in front of you: sleepiness, disease severity, meaning central sleep apnea, apnea-hypopnea index, oxygenation, and then also mortality, hospitalizations, and cardiovascular events as very important outcomes. So these were the highest ranked outcomes. And then we put some value too on other things that are reported we know relevant to our patients, such as fatigue, sleep quality, sleep architecture, continuity, and these other measures that we sleep physicians spend our days taking care of for our patients. And then we issue the recommendations. And so after you put all that into the blender, you come out with these recommendations. But it's a pretty standardized process. So this slide summarizes for the audience all these guidelines. So if you don't get to ever look at it, and for the busy clinician, one can, and I'll spend a few minutes here, but we have another approach to looking at it coming right up by Dr. Randerath as well. But this is published also. So on the first column is the intervention, and you will notice we have the intervention versus no intervention, because there is no literature, really very, very limited literature comparing different modalities. So we don't have adequate studies looking at ASV versus CPAP, BiPAP with backup rate versus BiPAP without backup rate, oxygen, versus CPAP. I know people may point to a study here and there, but they have to have the duration of follow-up and the outcomes of interest as well. So we had to set the questions as doing the intervention versus not doing said intervention based on the design of the studies. And we looked at these particular interventions you see in this column, but there are other things you may hear about, some medications that are emerging and they don't have sufficient studies. So the acetazolamide was selected amongst all the pharmacological intervention because it had more studies. PAP or mask-based therapies, including CPAP, ASV, and BPAP, and oxygen, and also importantly, the TPNS versus no TPNS. We looked at, I'm going to just have you jump to the population. So you see where the studies were available. I'm sorry, actually, it's the first, back to the same slide, Robin, sorry about that. The population is where the particular intervention was studied. So acetazolamide versus no acetazolamide, the data were available in CSA due to heart failure and primary CSA. for CPAP versus no CPAP, and for I'm sorry, let me just back up here. For all these ones on top, acetazolamide, CPAP, ASV, and BPAP without backup rate, the studies included the populations of primary CSA, CSA due to heart failure, CSA due to medication, CSA due to medical condition. And the level of certainty of evidence and recommendation are in the center. So these therapies were recommended. BPAP without backup rate was had a recommendation against it because it has the tendency to, especially if it's used with a wide pulse pressure support, to destabilize the breathing pattern. BPAP with a backup rate was evaluated in these populations: primary CSA due to medication, CSA due to medical condition, and treatment emergent CSA. And there is a conditional recommendation for it. And, same thing applies for the rest of it, as you see below. We did look at high altitude central sleep apnea in a different light because it's a very transient condition. So interventions like oxygen and acetazolamide may make more sense than PAP-based therapies, which take a much longer time to set up. And there were conditional recommendations for both oxygen and acetazolamide. There is a much probably more intuitive way for clinicians to look at this based on the condition you're seeing in your patient. And that will be the next slide, and I will ask my colleague and friend, Dr. Randerath, to walk us through this.
Thanks a lot, Rami. And really, it's a pleasure to be here, Robin and Jamie. And it was a great honor and a pleasure to work with you in the guidelines procedure. It actually was one of the greatest experiences I had in my career. Because of the robustness, because of the methodological, straightforward approach. And this slide gives you the same information as you heard from Rami in the last slide, but without the scientific background. So Rami showed you the scientific background. This is maybe the translation from a clinical point of view. So on the left-hand side, you see the different entities of central sleep apnea, primary central sleep apnea, heart failure, medication or substance use, and so on. And then you can see in the next columns which treatment options are recommended, conditionally recommended, of course, and which is has been recommended negatively against. So you can see for heart failure, we have a positive recommendation for CPAP, for adaptive servo ventilation, for low flow oxygen, for acetazolamide, and for TPNS. And you can translate it to all the different entities, and you see some differences because, for example, for low flow oxygen, we had not so many data in the different entities. We have negative recommendation against bilevel without backup rate, as Rami already mentioned, but a positive recommendation for bilevel with a backup rate. So you can see here also some comments which were added, for example, for adaptive servo ventilation and also for transphrenic nerve stimulation. We recommend to use ASV in experienced centers to start with the treatment. Of course, we will discuss that TPNS has some different aspects on the application, but this gives you an overview on how a clinician could approach to a patient with some of the entities of central sleep apnea. I would like to just go back, Robin. If you focus on the adaptive servo ventilation, here you can see that it is recommended by the ASS for almost all entities. And as I mentioned, we can apply it and initiate it in experienced centers. If you focus on this, we can go to the next slide, which starts demonstrating the EIS and ESRS update, which is actually a statement, not a guideline. And so that means there are some differences as compared to the ASM guideline in terms of methodology and also in terms of the spectrum we addressed. The idea of the ERS-ESRS statement was to pick up the difficulties clinicians had when they knew about SURF-HF trial and saw the more recent trials, for example, the Advent-HF. And so that means we were not really clear how to proceed and what to do. So clinicians required for advice, and therefore we started discussing just on adaptive servo ventilation, not on the other treatment option for the ERS and ESRS statement. Next slide. Rami pointed out how the methodology of the AASM guideline was. So it was based on the PICO and grade procedure, extracting data, grading them, and then coming to a recommendation. A statement in the ERS methodology is also a highly scientific approach, but it's not on the same level like a guideline. So it also requires a systematic search, a systematic review of the literature, but does not the grading and the extracting process as a guideline does. Nevertheless, our systematic search focused on major adverse cardiac events, on cardiac surrogate parameters, on sleep parameters, and importantly, also on patient-reported outcomes. What we found was during our literature search and the analysis of the literature that we, similar to the AASM guideline, or on the same with the same result, that we did not find any harm of ASV regarding, for example, major cardiac outcome, deaths, and so on. There were positive effects on patient-related outcomes. The findings on cardiac surrogate parameters or sleep parameters were not as clear as the effects on MACEs and patient-reported outcomes. So we gave a positive recommendation, next slide, for the use of ASV in different situations. So the first step is if a patient presents with central sleep apnea, we have to ask if it's on the left-hand side a comorbidity, so with predominant obstructive sleep apnea, or if the central sleep apnea component is predominant. If obstructive sleep apnea is the leading component, we start with CPAP and then switch over to adaptive servo ventilation. If central sleep apnea is predominant, we still have a focus on the severity of the left ventricular, the reduction of the left ventricular ejection fraction. However, as you can see, we stated that adaptive servo ventilation can be used in all clinical situations. However, for those with a limited ejection fraction, we recommend to use it in experienced centers. This is not because we are afraid of side effects or afraid of complications, but to get the community get used again to a treatment which has been banned for several years. If a patient has a really substantially reduced ejection fraction, for example, below 30%, that means he is in a palliative situation. So the mortality within 1 year is very high in this population. So for this group of patients, any option which might reduce the burden of the disease for patients can be used. This can include CPAP, oxygen, and also adaptive servo ventilation, but always with a focus on symptoms. So the main message from the statement is there is no harm. We cannot find harm in the devices used currently. However, we don't see a benefit in terms of survival. Therefore, the indication to treat is based on symptoms of the patients.
So I'm going to start with a case today. Many of you know that my background is in cardiology. So I, of course, picked a patient that would not have been uncommon for my clinical practice. And I just like to walk through and see how you'd approach it and what things could we maybe even change to make things better for our patients. So I have a 55-year-old male who presents to his cardiologist complaining primarily of fatigue. He has a history of hypertension, coronary disease, and paroxysmal atrial fibrillation. He is currently in sinus rhythm. He's on metoprolol, aspirin, and atorvastatin. Heart rate is fairly well controlled at 70 with a fairly well-controlled blood pressure at 126/76. Respiratory rate is 14. BMI is 35, so a little on the higher side, and he's currently in normal sinus rhythm. So I will tell you, I've done this before. As a cardiologist, I would have focused primarily on his cardiovascular risk factors here for fatigue. And the first thing I would have done is switched him to Nadolol, has a little bit less fatigue than metoprolol associated with it. I would have recommended weight loss. And then finally, I'm like, oh, sleep study. So your cardiology colleagues out there probably don't think this first still. So we do need to get the word out that sleep study probably should have been a little bit earlier in my process. But I did. I found out that as I asked questions, he occasionally snored. He didn't sleep well at night, and he was getting up 5 or 6 times at night to go to the restroom. So now I sent him straight for a sleep study. I didn't necessarily send him to the sleep clinic first. And here are the results. His AHI was 42 with an obstructive apnea index of 4, a central apnea index of 3, but hypopneas of 35 events per hour. And on this report comes back the recommendation for auto CPAP. So I'm going to stop there and say, how should this, is this the right way that patients should be evaluated, or what your thoughts are here just on this initial evaluation? And maybe Rami, I'll start with you.
Yeah, I thank you. Yes, I mean it's very interesting. I mean, I'd say it's like almost like a dilemma, interesting patient, because you look at the breakdown of events and it's almost 50-50. So as you try to classify this patient, based on our traditional approach and say if more than half of the apneas are central, they're central, or more than half apneas are obstructive. But based on apneas, I mean, it's almost, and then you have substantial, so it's a hypopnea-based sleep disorder breathing almost, or hypopnea predominant. And I would wonder here if there was one way to differentiate or see what kind of pattern that they went into. But as I look at how the patient responded to auto CPAP, and I see that the device download is reporting. And I think, we all have some reservations on what a device download and how accurate and all that, but it is reporting a problem. And obviously it's a problem that requires attention because the patient has very limited change in his AHI, number one, so they're not deriving benefit. Number two, the events are detected by the device as central. So the question is this, what you would call treatment emergent central apnea, or was it central apnea to begin with and it's a treatment persistent? So I'm definitely wanting to classify the disorder a lot better and understand the impact of these hypopneas on this on the breakdown or on the classification of it.
So Professor Randerath, at this point, what would you use? What would you even call the diagnosis here? And what do you think the next step might be?
Yeah. First of all, I would like to say that I would not blame the physician for how he performed here. So, because many home sleep devices, test devices, do not allow for differentiation between obstructive and central sleep apnea. So, this is a problem which has been realized in recent years. But this case really nicely shows that how important it is. Because as Rami said, this could be named treatment emergent. But from my point of view, the first step when we discuss about treatment emergent is to go back to our first study and ask ourselves, did we well? Did we really understand what happened? And therefore, I think it's of crucial importance to try to differentiate the hypopneas. And you see, for many studies, this is quite normal that the majority of events are hypopneas. And therefore, if we say we have obstructive hypopneas, why shouldn't we have central hypopneas? So there must be a range. And this has been nicely shown not only by this study, but also by others. But this is the most recent one, I think, which shows if you focus only on central apneas on the left-hand side of the figure, you misclassify the disease. So as you can see, it was classified as obstructive sleep apnea in the majority. But if you focus on central and apneas and hypopneas, the picture changes, and you see that there are substantial coexisting, a proportion of coexisting obstructive and central sleep apnea, and also increasing number of central patients classified as central sleep apnea. So this shows that in our clinical practice, there are many patients who might be misclassified and then also mistreated, like this one, who was treated with APAP without significant effect. However, it might be difficult, or it might be asked for some additional consideration how we can differentiate. From my point of view, it's possible at least by 70% in clinical routine if we focus on the flattening of the flow curve, which is a clear indicator of obstructive events, the paradoxical breathing between thorax and abdomen effort. So paradoxical breathing is again an indicator of obstructive sleep apnea. By the increase of the ventilation, if it's a crescendo increase or sharp increase, sharp is more obstructive, a crescendo increase at the end of the event is an indicator of central events. So this gives you also from the home sleep testing some good ideas if it's more obstructive or more central hypopneas. So it's worth considering because this has immediate clinical implications.
And I'll just point out, you have wrote a lovely paper explaining that methodology that's available as well, which can be really helpful if a center hasn't utilized that in the past. So this patient was then sent in for an in-lab PSG based on that, and luckily they did get a full diagnostic PSG, which again showed very similar levels of apnea, but almost a significant portion here of central hypopneas. But there were actually more obstructive apneas than central apneas. So, Dr. Khayat, what would you call the diagnosis here?
Yeah, so I mean, this would, in my perspective, from my perspective, be central apnea syndrome, because I mean, you go through the effort to classifying the hypopneas, and they are predominantly central, so we cannot ignore that. Especially that if you notice the breakdown is really pretty close, and that's probably within the standard deviation of the test. So this is meaning like within the score agreement that you may the flip. If this was like say 35 OAs and 10 CAs, it's one thing, but this very close, and that can flip. But then there is a significant split in the hypopnea. So to me, it's actually there's very little question that this is central sleep apnea. And then when I put that in the clinical presentation too, in the way the patient responded to auto CPAP and some of the background of the characteristics of the patient, it makes a strong case for central sleep apnea, which I would say obviously this is a baseline polysomnography, so it's a central sleep apnea at baseline. It's not just so this is not the classification of treatment emergent. But it is a very interesting concept when the actual classification happens and how that affects the treatment decisions. And I totally agree with Winfried that we have to get this done early because it can save the patient time too. If this one maybe was knowable a little earlier before the treatment was initiated, so it would have been a good time to be more certain that this was central, not obstructive. And perhaps we would have, thought of the treatment from a different, maybe they wouldn't have been as responsive to other CPAP in our mind, if we knew that earlier.
So for centers that don't classify hypopneas for all patients, is there a number of central apneas that give you pause to say we need to take a second look, especially maybe on a home study? Or is it any central apneas? When should that kind of awareness arise? Professor Randerath?
Well, I would not put that on the number of apneas or so.
Okay.
I would not be able to give a figure. But to be honest, I often start in my clinical practice with CPAP as a first trial. And when I see that it doesn't work, when I see that the events are not resolved or even increase, then it's a clear indication for me to switch over to another treatment. So or to reevaluate my first study. When especially like in this case when central events increase. A CPAP trial is also good from another aspect. If it's central sleep apnea, as you saw in the AASM guideline, we recommend CPAP as one treatment option. So if it works, it's cheap. But if it doesn't work, it also has another positive effect because it gives you an idea what the expiratory pressure should be. Because we have many patients who have coexisting obstructive and central sleep apnea. So I would not figure, as you asked, on the number of central apneas as an indicator if this might be more obstructive or central. Um, I would actually often use a CPAP trial.
Great.
And I'm glad you asked Winfried that before me. So, but I do, I mean, I subscribe to the benefit of the CPAP trial as well, but I think going in like a little bit more informed helps you make that trial. Like, for example, you could do it in the lab to start with
Yes.
and identify the pressure and then make some decisions so you can shorten the patient's time to acceptance of rejection of like PAP-based therapy, for instance, and doing it right, figuring out the right interface and all that. So, but a candidate for auto CPAP does exist too, based on a home sleep test, and we don't want to discount that. So some people will benefit from this approach, and others, if you find some nuances on the sleep study. But yeah, I totally agree with Winfried too. I don't know any number of central apneas, but you know, depending on your lab and the device you're using and all that, you can, like, some flags can be raised sometimes that you are seeing some centrals here that could stand for, risk of central apnea. And if you're not classifying hypopneas, maybe you just flag that. I put that in my report. There is some, I look at the other features and say, central apnea is observed, or something like that. So if one of my colleagues is seeing that, they at least can get prepared mentally to how the patient will do on CPAP, or consider doing an in-lab like split study or something like that. So
Good idea.
Now, this patient didn't have a diagnosis of heart failure. And so I often get asked questions of, is there any further workup that you would need to do? Now, I mean, this patient did have some cardiovascular disease of atrial fibrillation, but is there anything else that you would want to do as a sleep clinician before maybe you go to the next step? Professor Randerath?
Of course, I would reevaluate him or ask a cardiologist to reevaluate him. So to see if there's anything which can be improved. This should always be the first step. Can the cardiologist improve his or her treatment? And so that would be the next step for me.
So, and they did get an echo for this patient, which showed kind of this mildly reduced ejection fraction of 40%. So what are we gonna do next, Dr. Khayat?
well, I think, for something like this, I would be doing in-lab titration, for example, to see what they would respond to based, again, on the ASM guidelines
Hmm.
is, PAP-based therapies are generally more available, easier to manage everywhere. I would start with that, assuming the patient is still willing to try after their negative experience, but assuming their experience was negative with that high residual AHI. But I would put them in the lab and try. Now, as far as we know, CPAP as auto maybe has failed. It's possible to try it in the lab and see if it didn't, and then ask the technician to move on quickly to these other modalities. The American Academy didn't comment. The ASM guidelines didn't provide recommendation on BiPAP with backup rate for heart failure, central sleep apnea. There were no studies, or the studies that were available couldn't be. There was just very acute, like 1 or 2 nights and all that. So they didn't make the cut. So, and the experience with ASV is, adequate. So I think we could get into a bit of we would need probably a lot more time than allotted to us today to decide on what ASV and how. But I would potentially consider either one, depending on the availability of either unit. If something can show me adequate control of the sleep-sorted breathing on the sleep study, I would prescribe one of these devices. I prefer ASV because I know it's more likely to control it than BiPAP with backup rate. But I think either one that controlled the SDB, and I would be following up the patient to ensure that they're not being hyperventilated or delivering, receiving too much pressure and or discomfort. So I would be following this patient at much closer intervals, knowing where their ejection fraction is and that they do have asymptomatic systolic dysfunction. So I want to make sure they're not exposed to certain harms, especially if my device was minute ventilation based ASV or something like that. So that's kind of in a capsule how I would go at this. So
Professor Randerath, any differences? Obviously, you're practicing outside the U.S. in Germany, which has been dealing with ASV for a long time. Anything
Yeah.
else that you might add to this?
Yeah, so I actually agree with Rami. We use ASV continuously, of course, reduced in the last years, but now changing. Our experiences with ASV are good. And the difference between bilevel and ASV, from my point of view, is bilevel is a very hard treatment. So you have one inspiratory pressure, one expiratory pressure, you have a backup rate. So this puts the device's algorithm on the patient. So you do not have flexibility, you do not really address the problem, you avoid apneas. This is what the backup rate does, but you do not really influence the pathophysiology. On the other hand, ASV is designed and built and performs like this, that it counterbalances the overshoot and the undershoot of the ventilation. And in addition, the modern devices also apply variable expiratory pressure. So they adapt to different components of the pathophysiology. And after a while, you see that the breathing normalizes. So it's not only on the one hand, maybe you achieve with both devices suppression of the breathing disturbances, of the apneas, but what you do better with ASV is to influencing the pathophysiology. So therefore, I clearly prefer ASV.
Thank you so much. And so for this patient, that's exactly what the patient was put on. He was put on ASV, felt much better, improvement in his fatigue. The device AHI at least was 1 event per hour, and this patient was released to annual follow-up. And Dr. Khayat, you mentioned a little bit because this patient's ejection fraction was down a little bit. How often are you typically following these patients?
this is in my own practice, I will see a patient like this minimum of every 6 months, not every year. but occasionally I will see someone every 3 months, and you will know way better than me if those were like within a heart failure clinic, they're often being seen. So I've developed partnership in the past with my heart failure colleagues where they're looking for my outcomes and I'm looking for their outcomes too. So, it should be complementary like this. So the heart failure specialist is looking at the patient and asking them, using the device, still getting benefit, tolerating everything, fine, you can wait for 3 months to see Khayat then. And so we were kind of doing things like this. But some patients do very well, and it's a clinical, judgment too. Your patient here is not, in symptomatic heart failure, it sounds like, but has fatigue and
Mhm.
whatever the attribution is it to the sleep-through breathing or the heart failure, and maybe can actually be released to annual. Maybe it's appropriate in their case. They responded well, and they're seeing their cardiologist enough that the sleep physician can see them once a year. But I would say it's just going to be on a case, to case basis.
And I know you both have very busy clinics, but Professor Randerath, do you have a way if this patient kind of quit ASV? Is there anything that you would do to follow them? Are you doing any of the remote monitoring of these devices?
Actually, in my clinic, we don't do remote modeling, monitoring at the moment. This has to do with availability in Germany, which is quite difficult at the moment with reimbursement and so on. However, we try to see the patient for the first time after 6 weeks. And what we know is that patients who have a good adherence in the first days and the first weeks of the treatment, then we can expect a good adherence. And then we offer them telephone contacts if they have problems. And we would see him for the next time, as Rami said, depending on the patient. So routinely, we'd see this patient, which is a patient with different problems, after 6 months, and then in a year on a yearly base, if nothing special happens.
Great. And that's what happened with this patient. But now he comes back after about 4 years. He's had recurrence of his atrial fibrillation. His fatigue has returned. He's not wearing ASV most of the nights because he's started complaining of a lot of aerophagia, swallowing a lot of air. And on top of that, he has gotten divorced and does not want to wear his mass-based therapy because of more social factors, I would say. Um, so, so how would you approach this patient? Maybe I'll start with Dr. Khayat. What options do you have now?
For the divorce and dating, I have no idea. Far as the swallowing air and other things, again, I would do some troubleshooting to see why the rejection of the therapy is and when it took place and all that. And yeah, occasionally, we have two kind of paradigms here. Sometimes we insist and we continue to work with them, and we lose the patient again. Sometimes the patient they really don't want to do it, and others they don't want to use a mask-based therapy or PAP-based therapy just because it wasn't done properly. So my first thing is to figure out if this patient, when they were lost to follow up, what triggered their rejection, other than, but say they're very solid. I don't want to use this therapy. We do have other options, especially, the TPNS and other things are available for patients who reject mask or PAP-based therapies, assuming a fair trial has been given. And I think this is way far out that the patient probably will say, I've been doing this for so many months, I'm ready for neurostimulation. It's the same paradigm as when we would do HNS, for example, for a patient with OSA who benefited from therapy briefly, but doesn't want to do PAP anymore. And I can speak to this too,
Okay.
that these are the three other options from the guidelines. And I personally, and I would be curious to see what Winfried says about the oxygen and acetazolamide. I have less experience, and some of the things we hear is oxygen is a little difficult to get it covered. Number one, if the patient doesn't actually have, the CMS level of desaturation, number one. We have no evidence that it's better tolerated, for example, or even it treats the disease process as well as, like, say, ASV did or TPNS. There isn't really a rigorous randomized control trial. I do offer it here and there. And acetazolamide, I will admit that I want to get better at using it. I know some of our colleagues, maybe some watching us now and all that, use it more often, but I don't have like an experience for someone using it for a year. I have prescribed it here and there, but these weren't the patients I was able to continue to see. So I tend to move quickly to the TPNS, but I may stop a little longer on the oxygen than the acetazolamide. And I really want to learn from Winfried's approach to this too, because it's a little less charted even by the guidelines,
You can't learn anything from me. You know everything. But I have same thoughts. And I think the good news from the AASM guideline is that we offer different options. We did not make a head-to-head comparison. This is a benefit that might also be a problem. However, if we come back to the data, we see that the data for oxygen and acetazolamide are less evident as compared, for example, to TPNS. So we have more data and longer-term data on TPNS. Like for the other treatments, the groups are smaller also for oxygen and acetazolamide. I use both in individual cases. However, for this person, I would use oxygen or acetazolamide for more critical situations. For example, elderly patients who can't use any other treatment, patients who do not wear any mask, but the problem is less difficult, like in this case. So in this case, I would exactly follow the road as it has given in the case. So positive airway pressure, then ASV, and then for this case, I would prefer TPNS.
Great. Well, Dr. Khayat, do you want to give us a little bit of background? You've been involved in some of these studies for a long time. This is just a guideline slide. I'll let you take it from here.
Yeah, thank you. And obviously it's great to have the options now for our patients. So and they are different. That the difference in these options is actually a strength, not a weakness of guidelines and of our ability to care for these patients. So a couple things that came out of the guidelines that must be emphasized is not to leave the patient. So, now obviously if the patient doesn't want to follow up, that's a different story, but we do need to give our patients I keep on calling this chronic disease management paradigm. Patients have to be seen in regular intervals to make sure they're doing well. And, our colleagues in Japan do it every month. So we obviously do not want to burden our patients with that frequency, but we have to figure out what works for our patients. But we do need to, so the guideline says, clinicians should focus on patient-reported outcomes over disease process metrics as well, meaning that sometimes patients, because most of these therapies didn't show mortality benefit. It's not like guideline-directed therapy for heart failure, for example. These therapies for central sleep apnea are fully interlocked into the quality of life and the patient-reported outcomes. So if the patient is not benefiting from the therapy, then we do need to release them from it and have a good, shared decision-making and say, look, nothing is working. You don't need, nothing's going to work for you. It's okay. But if we can make the patient feel better, it's, our duty to keep on offering them, therapeutic options, looking at the patient outcome. Do they feel better? Are they sleeping better? Are they, having more daytime energy? And I will also add to it the nocturnal hypoxia is very important too as a surrogate of bad outcome in heart failure and comorbid conditions. So if a patient didn't do well with one therapy, we need to move on to the next one. And that's what we're doing with this patient here. and then offer them the next available thing. So, a few words about the transvenous nerve stimulation, which is now FDA approved for central sleep apnea. It's technically the only FDA approved therapy for central sleep apnea. It's implantable, fully implantable, similar to the hypoglossal nerve stimulation, and which most practitioners are very familiar with now. It stabilizes the breathing by activating the diaphragm, generating more natural negative pressure breath. And it comes on automatically at night, eliminating that burden of decision making when the patient goes to sleep. So it consists of the pulse generator and the stimulation lead, basically. And the cartoon here shows how that looks like. This is the pulse generator in the right thoracic area, and the stimulation lead going to the phrenic nerve. So and the device can be programmed, and I think it's very important for people who are not familiar with it as they start entertaining offering this or counseling patients, that the system comes on automatically at night, so the patient can influence how it comes on by elevating their head, for example. But if they happen to be lying in bed in the programmed habitual sleep time for this patient, the device will come on. You can build in some latency and work with numerous customization to improve the patient's comfort, but it does come on automatically and turns off automatically when their wake-up time is programmed and they're up now and moving. And they can, like I said, control it a little bit with some of the movements. And we can set up different stimulation thresholds for different positions and the patient's preferred sleeping position and all that. When we evaluated this in a randomized controlled trial, there was significant improvement in all the preset primary outcomes, but very well tolerated procedure, very limited adverse events, no long-term, sequela for the implant or for the therapy, no negative outcomes basically here. But I don't think we'll have time necessarily to go over all the things that got changed and improved for our patients. But we know that sleepiness, sleep quality, oxygenation, patient-reported outcome, all these things improved in that trial.
Great. So to wrap it up for this patient, he got implanted fairly quickly. It was activated a few weeks later, and now you can see his titration PSG ended up with an AHI of 12, with primarily a few obstructive events left over, but fatigue was greatly improved. He's sleeping well, and he was then moved up to a 6-month follow-up. And I just ask, how does this compare to, you've had a number of these patients in the past, how your patients have done with this therapy? And then I think we have a number of questions.
Yeah, I'll be quick, and I think I can talk as we call up the questions, Robin. But this is typical response. Patients do really well. They like the liberty of the treatment, and obviously, good counseling upfront is important to know what the expectations are. And like Winfried mentioned, there are some sleep studies and a procedure, and some patients, maybe they're not necessarily interested in a procedure, but those who are able to do this, it's a great option, and the response is not unusual.
Great. So we'll come back to this in just a second, but let's stay here just a second. A couple of questions that came in. One which I think has come up probably in every one of these presentations on the new guidelines, and you've talked about it, but we do have some cardiologists that are on and listening in today, and they're a little confused because of SERVE-HF. A lot of the cardiology guidelines have contraindicated ASV, especially in class 3 lower ejection fraction patients. What data has changed or given confidence that you're not putting these patients at risk? And I know we don't have time for a really detailed discussion, but at a high level, maybe Professor Randerath, if you want to talk about some of the newer data that's brought this back into part of the treatment pathway.
Yeah, thanks a lot, Robin. This is really a very important question because this shows how that we are still uncertain how to proceed. Um, but the evidence, as figured out in both the statement and the guideline, showed clearly that the putting together all data of the last 10 years, so including SURF-HF, not only others, but including SURF-HF, did not show any harm. So the data, if we put together all data on ASV, we actually don't find the difference. And this might also be, please keep in mind that SURF-HF has been performed with a device which is no longer on the market for 10 years and an algorithm which is not used. It was a very hard algorithm with a fixed expiratory pressure, with a minimum pressure support, which did not really um, adapt quite well to the situation of the patients. So putting together all data um, in a methodologically robust meta-analysis does actually not show any difference in mortality. So this is not only driven by ADVENT-HF, the most recent study, but by the summary of all data available, including SEARCH-FF. So this is really a change, a paradigm shift from my point of view, which has been accepted by all three societies, AASM, European Sleep Research Society, and European Respiratory Society, and it also endorsed by other scientific society, including Heart Failure Association.
Thank you so much. I think I do think it's really important. And I don't know that our heart failure study in the US has weighed in on that yet. But I agree. I think the Heart Failure Society in Europe has weighed in already on this. So yeah, I think it's very interesting. Um, Another question, really different question. So uh, PAT signals. How are you? So the question here is sometimes they will get a PAT study that shows a lot of centrals, but then when the patient comes into the lab titration, they don't always have the same number of centrals. How are you reconciling that? Is there a reason that it might call that? I I'm not an expert on that, so I will maybe Dr. Khayat.
I can make a guess, honestly, but I think, these are two moving parts in a sense. One of them is how the central events are actually scored in the lab, in the specific lab that Mikhail is dealing with, Dr. Aronoff, because there has to be the watchpad is probably detecting the breathing pattern, the rhythmicity, the periodic pattern, and that periodic pattern may or may not uh, be scoreable as central event number one in a PSG. So, but on the other hand, it actually may very well be um, central hypopnea. So if the lab doesn't really score central hypopneas, then they're not going to pick it up too. So I would say it just depends, number one, on how in tune the sleep lab is to scoring central events. That's very important. Uh, but I do agree with him that it does overcall because of that rhythmic pattern or the which may or may not always be central apnea. So that's it's a pros and cons of each screening device that we have.
Well, wonderful. I want to thank you both very much for being here today. These are some of the messages that I think we heard that many of these patients have a lot of underlying diseases and they need to be optimized. So, this is one of the reasons I think we saw in the guidelines talking about, a specialized centers where you do disease management and working with other specialists to make sure these patients are cared for. That all of these treatment options are needed and patients need to be aware of them because different patients may need different therapies. And then we didn't talk about it a lot today, but maybe something making sure these patients don't get lost because they get frustrated over time. And then some shared decision making. You brought up Dr. Khayat a lot on symptom burden. So I know we ran over just a couple of minutes today, but I really appreciate everyone attending, and specifically Professor Randerath and Dr. Khayat. Thank you so much for spending your afternoon, evening with us here. We had a very nice turnout today, and I very much appreciate you sharing all of the work that you did to develop these guidelines for us. Thank you so much.